If you're facing a hip replacement, there's a fear we should all say out loud. Will your new hip pop out? So let's answer it honestly. Dislocation is uncommon, and yes, overall, the research has tended to show lower rates of dislocation with the anterior approach. But that's not the whole story. Newer data shows a posterior approach done with modern technology like robotics can rival those numbers. So this isn't about one approach being good and the other being bad. In fact, the most important factor isn't the approach at all. It's the surgeon doing it. Let me show you what this really means for your hip. First, what are we even talking about? A dislocation is when the ball of your new hip pops out of the socket. It's uncommon, but the fear sits in the back of your mind. So why would the approach change the risk? It comes down to how we reach the joint. With the anterior approach, we go between two muscles in the front of the hip. We move them aside. We don't detach any muscle. The muscles and tendons at the back of your hip stay intact. And that back tissue is a big part of holding the ball into the socket, so the hip is more stable from the moment the surgery ends. Here's something that puts the fear into perspective. When a dislocation happens, it's usually within the first few weeks while everything is still healing. That's the window your soft tissues are essentially knitting back together. After that, the risk drops off significantly, although never really zero. The two things that drive the risk more than anything else, one is where the parts are placed during surgery, and that's on me. The other is how the hip is handled in those early weeks, and that part includes you. That's the whole reason precautions exist after surgery, not to scare you, but to protect that healing window. And let me answer the question you're probably afraid to ask. What if it does happen? What if the hip does dislocate? For most people, a hip that comes out of place can be gently put back into place without another big operation. In fact, 2 out of 3 times, if you have a hip dislocation, it never happens again. It's only the rare hip that dislocates over and over that needs something big done, like another surgery. I'm not telling you that to make it sound trivial if it does happen. I'm telling you that so the fear doesn't get bigger than the actual risk. Because the actual risk for you, for most of you, is very small. So now to the real question, does anterior approach actually lower the risk of dislocation? Overall, the literature has certainly leaned that way. One large study found the anterior approach carried noticeably lower odds of dislocation than, for example, the posterior approach. And I'll be fair, because honesty is part of this whole channel. Not every study agrees with this. Some high-quality reviews find the difference isn't statistically significant. So the accurate way to say it is this. Anterior approach shows lower or comparable dislocation rates, but not a night and day gap. And that's exactly why anterior patients are given almost no restrictions afterwards. The stability is built in to how the hip is reached. Now, here's where the story gets a little bit more interesting and more honest. Newer research is showing something important. When the posterior approach is done with modern technique and technology like robotics that improves how components are positioned or used, the dislocation rates come very close to the anterior approach. In some studies, they're nearly the same. Because a lot of dislocation risk comes down to one thing, where the parts are placed. Get the positioning right, and it takes away a lot of that risk, whichever door you use to get there. So I don't want you to walk away thinking posterior is the wrong choice. It isn't. This isn't approach worship. It's just why the earlier rule book can look so different. Let me show you that rule book side by side. With the anterior approach, I give you essentially one precaution. Avoid the extremes of motion, like putting your ankle behind your head. That's it. Patients brace for a long list of rules that never comes. The posterior approach is different early on. It comes with a list of classic hip precautions. Don't bend your hip past 90 degrees. Don't sit in low chairs, and don't cross one knee over the other. Those usually last for several weeks until everything heals in. Now, hear this part clearly. A few weeks of restrictions does not mean a worse hip. The approach with more rules early on can still reach the exact same strong, stable result. It could be a slower start, but the same finish line. So, which one should you choose? Here's what I tell every patient. You're going to do very well no matter which approach your surgeon uses. The best approach is the one your surgeon does most often and feels most comfortable doing. And I'll tell you something else that surprises people. There are times I choose the posterior approach myself. Anterior isn't right for everybody. A complex deformity, certain body shapes, or hardware that's in place that has to come out, all of those can benefit from a posterior approach. So this has to be customized to you, and your surgeon has to be familiar with the approach they pick. You're not shopping for a brand name or a specific approach. You're looking for someone who does your operation often and does it well. Let me tell you why repetition matters so much here. You might think that after doing thousands of these, all hips look the same to me. The opposite is true. The more hips I do, the more I notice those small differences from one hip to the next, the little nuances that change how I position the components for that patient. And positioning helps protect you from a dislocation. That's why I've dedicated my entire practice to just hip and knee replacement. So here's a fair question to ask your surgeon sitting across from you. How many of these do you do? And which approach do you do most often? A confident answer tells you a lot. You want experience, not a sales pitch. Now the part that I'll admit gets under my skin just a little. The marketing around the anterior approach. You'll see claims, go home same day and don't miss any work. And look, that can happen. I do the anterior approach on nearly all my hip replacement patients, and some recover remarkably fast. But that's not the right expectation to walk in with. This is still a major surgical procedure. There are still real risks, and it deserves your respect. Here's why expectations matter so much too. For example, in knee replacement, the single biggest predictor of an unhappy patient isn't the surgery itself. Its expectations weren't met. The same holds true for hips. If marketing promised you a weekend of downtime and then back to everything perfect, it's just not a realistic picture, and that can make you really depressed. How fast you recover depends on how strong you are coming in, and when you get back to work depends on what your job asks of you. It really has to be individualized. A quick bit of background here because I think it helps. The anterior approach feels new in marketing. It isn't. It was first done way back in the 1940s. It was popularized here in the United States by a surgeon named Joel Mata in the 1990s. And every year, it's a large share of the hip replacements done now in the US. So what does recovery actually look like after an anterior total hip replacement? You can put your full weight on your hip right away. The walker is there for your balance, not because the hip can't take the load. Some people barely use the walker, actually. You can move to a cane whenever you're ready, and you can drive once you're walking steady with that cane and off all your narcotic pain medicine. One honest note on the speed, though. The recovery benefit from this anterior approach shows up most boldly in these first several weeks. By 6 months to a year, whatever approach you use, they all even out. Same strong hip, either way you got there. So let's bring this video home. Dislocation is uncommon. The anterior approach does tend to have a lower risk of dislocation than the posterior approach, but a posterior approach in skilled hands with good technique comes very, very close, if not equal. The fear is understandable, but it should not run your whole decision. Find a surgeon who does a lot of hips and does them well. Go in with realistic expectations and you'll do well. If you want to walk through your own hip journey, there's a link to schedule a consultation below. Either way, hope you'll come back here, participate in the conversation. Thanks for watching.